Hey guys, today's lesson is chapter 16, which is Musculoskeletal Neoplasms. Remember, neoplasms refers to cancer or tumors, and musculoskeletal means that these tumors are going to be arising from either the muscular or the skeletal system. I will give you a disclaimer, this is not the most entertaining lecture we're ever going to have, but we are going to get through this together. So, quick overview. Again, neoplasm means tumor or cancer. Cancers can be either benign or malignant. Benign means that it shows no tendency to metastasize, usually stays relatively local or non-invasive, usually pretty slow growing. Malignant means that it can be invasive or metastasize to another site. As I mentioned earlier, primary tumors are tumors that originate in the tissue that we're talking about. So again, we're going to be covering musculoskeletal tumors here. Soft tissue means that it can come from muscle, cartilage, nerve, collagen, adipose, which is your fat tissue, lymph or blood vessels, or your skin, which we have covered already in the integumentary chapter. Bone means that it originates in the bone, and we'll talk about secondary tumors later. In this population, we may see some pathologic fractures, which means that bone is fracturing where it has been weakened by local destruction, which cancer can cause that to happen. All right, so let's talk about some bone tumors. Primary bone tumors, again, we have classified as either benign or malignant. The benign type of bone tumors can be a bone island, osteoid, osteoma. Sorry, I have a hard time with that one. You're going to hear me struggle for the whole lecture. And osteoblastoma. The malignant types of bone tumors are osteosarcoma, chondrosarcoma, and Ewing's sarcoma. So we're going to talk about each one of these individually. Bone islands are also known as enostosis. They are a lesion of compact bone within the cancellous bone. And you can see in these pictures here, those bright white areas, those are your bone islands. So they are usually oval shaped. They're small, sclerotic lesions of the bone. Sclerotic just means they're a thickened area of bone. They have been observed in all different types of bones, so they don't just show up in one type of bone. The lesion is usually well-defined, again, nice circular oval borders, and they are almost always asymptomatic. So signs and symptoms, there aren't any. People usually find out they have these by accident. They had an x-ray for something else, and they happen to notice one of these bone islands. So diagnosis is made by x-ray, and if your patient would be aware of these, just reassure them that they don't really pose any significant health concern, shouldn't cause any symptoms, really not really anything to worry about. Here are pictures. This one here is in the femur. We have one here in the humeral head, and then one here in the spine. Osteoid osteoma, again, also another type of benign tumor. It is very rare, and they're usually found in the cortex of long bones. So it can be found in almost any bone except for the skull. The cause remains unknown, but most are seen in men under the age of 25. The clinical manifestations or signs and symptoms include a local pain that's usually described as a dull ache, possible synovial effusion, so swelling in a joint, local muscle atrophy, usually again due to pain and disuse, and possibly an unexplained backache if it's located in the spine. Diagnosis is going to be radiographs or x-rays, a bone scan, or CT or MRI. Treatment could include surgery to remove the osteoma, bone grafting if they have to remove a large enough piece that it would need to be replaced, potential activity limitations and weight-bearing restrictions depending on the site of the surgery. Prognosis, recurrence is usually rare, and surgical excision usually leads to a full recovery. Osteoblastoma is the third kind of benign bone tumor, bone tumor that we'll talk about. It is a large benign bone tumor, often found in the spine, the sacrum, or the flat long bones. This occurs in the osteoblasts. Remember that osteoblasts are the bone builders. They're the cells that lay down more bone. And the difference between these and an osteoid osteoma is that osteoblastomas are often larger in size. So clinical manifestations could include pain in the area. It's usually not relieved by the use of over-the-counter medications, which do usually help to reduce the pain of an osteoid osteoma. Tenderness over the lesion. A functional scoliosis may be observed. Remember, we talked about functional scoliosis earlier in the term, where people sort of shy away or lean away from the area of pain, which could then cause adaptive muscle shortening. Neurologic deficit may be present, although it is rare. Diagnosis, as always, is going to be X-rays and CT or MRI. Treatment can include curettage, which is scraping to remove the tissue from the bone, or surgical removal of the tumor. 90 to 95% of osteoblastomas are cured with this initial treatment. Moving on to our malignant types of tumors, we have osteosarcoma. This is also known as an osteogenic sarcoma, again, meaning that it originates from bone. This is an extremely malignant type of tumor that has abundant sclerosis, which is, again, that thickening or hardening of bone. This is the second most frequent malignant condition of the bone. And the distal femur is going to be the most common site where these are found. Causes can be certain genetic or acquired conditions that can increase the risk, and these can be either primary or secondary in nature. Again, primary means that it originated here in the bone. Secondary means it metastasized from another site. We most often see osteosarcomas in young males, usually under the age of 30. Clinical manifestations, again, your signs and symptoms are going to be pain, especially around the epiphyseal plate. The epiphyseal plate, remember, is your growth plate. And these tumors seem to affect the growth plates most often. Pain usually lasts for several weeks to several months, and it doesn't seem to generally improve. Eventually, swelling will occur at the joint. And although it's rare, there may be a fever, occasional fever showing signs of systemic involvement. The skin may also feel warm to the touch. Diagnosis, again, is going to be X-rays, and X-rays should be done with any complaint of bone pain, especially around the knee. Bone pain, again, is usually considered or described as a deep, dull, achy sensation. CTs and MRIs, as well as biopsies, can confirm the diagnosis. Treatment for osteosarcoma is surgery, which means a complete removal of the primary tumor and any site of metastasis. The difficulty with this is that complete removal of the tumor means complete removal of the bone, which essentially equates to an amputation. That is going to be the treatment for osteosarcoma because it is capable of metastasizing and metastasizing quickly. It needs to be treated quickly and relatively aggressively. We will talk about these prosthetics or rotationplasties and the expandable prosthetic in just a second here. Chemotherapy may also be done after surgery or before in order to try to kill off those cancer cells. Osteosarcoma does not seem to respond well to radiation treatment. Prognosis, the 5-year cure rate is about 70 to 80%. All right, I'm going to go back a little bit to the surgeries. What happens then is if the distal femur, again, where this traditionally occurs, needs to be removed, that would basically result in an above-knee amputation for your patient. You guys haven't quite got to this in procedures yet, but if we can preserve a patient's knee and they have a below knee amputation, then that significantly reduces the amount of energy and learning curve that they would need to use a prosthesis. So we always want to try to leave as much limb as we possibly can. So to do this, there is an expandable prosthesis that can be used. It's a metal rod that replaces the bone. And then painless electromagnetic rays very, very slowly and gradually expand the rod, almost like the bone growing itself. A rotationplasty, now I'm going to move on to the next slide so you can see some pictures. A rotationplasty actually takes the cancerous part out, which would be the distal femur and probably part of the proximal tibia and fibula, salvages the foot, and as you can see here, the foot is then rotated 180 degrees, and the foot now becomes the patient's knee. This is why it's called a rotationplasty. It's a kind of wild procedure, but again, it takes that person from potentially needing or having an above knee prosthesis, which then has a computerized knee. It's not their own knee. They are much more expensive. They are much harder to learn how to walk on, and it gives them their own anatomic knee. It is their foot. They will have to relearn some motor planning in order to get that to work. But you can see over here, when this patient is fitted with the prosthesis, you can't really tell, right? Their foot, their ankle is now going to function as their knee. So this is a really cool procedure. You guys are actually going to talk about it a little bit more in your procedures class, but this is a way to help patients with osteosarcoma retain as much limb as possible. This is a video with a girl who has had the procedure, and she will talk to you about that. I will let you watch that on your own. Oops. Maybe. Okay, that little glitch there, but that video is there. You can watch that on your own. The next type of malignant bone tumor is going to be chondrosarcoma. It's a slow-growing malignant tumor of the bone. The common sites are going to be in the pelvic and shoulder girdle, the femur, the humerus, and the ribs. Clinical manifestations, again, signs and symptoms are going to be deep bone pain. And again, this does have the capability of metastasizing or to be a metastasis from the lungs, other bones, or organs. Diagnosis, again, is going to be X-ray or biopsy to confirm. Treatment is going to include surgery. Chemotherapy is going to be limited here. And prognosis is going to depend on the stage of the lesion and if it has metastasized anywhere at this point. They can, as we talked about in the oncology chapter, grade the tumors. Grade 1 tumor is less likely to metastasize. And with that, there's a good prognosis of about 80% chance of a cure. A grade 3 lesion is much more likely to metastasize, but the majority of chondrosarcomas are grade 1 or 2. So usually they can catch these in time. Ewing's sarcoma is a malignant tumor that arises in bone or soft tissue. The common sites are going to be the pelvis and the lower extremity bones, the femur, the tibia, and fibula. It frequently metastasizes to other bones, especially late in the course of the disease process. So again, clinical manifestations, signs and symptoms are going to be bone pain. Swelling occurs in about 70% of all cases. Pathologic fractures can happen more easily here, but it only happens in about 5 to 10% of cases. There can be a palpable or observable mass in the area of the tumor. And in children, we might see flu-like symptoms, and it might be misdiagnosed as osteomyelitis. So they will hopefully do x-rays to help diagnose. If anything shows up on x-rays, then they usually do further diagnostic testing such as CT, MRIs, or bone scans. Treatment, again, usually includes a multidisciplinary approach. Chemotherapy, radiation may be used. Immunotherapy is another option for this type of cancer, and surgery, again, depending on the location of the tumor. Prognosis, the 5-year survival rate has increased to about 70 to 80%, again, if the disease is caught early enough. Long-term survival, again, is largely dependent on whether or not this cancer has metastasized to any other sites. As far as PTA goes, with aggressive intervention, again, this could require amputation of part of a limb. So we would work with the patients usually after for prosthetic fitting and gait training, as we would with any amputee. Rehab, again, is going to focus on function, getting them up and ambulating again. And then there's, again, with any amputee, social reintegration. There's always a mental component with any type of limb loss, and then helping them to return to work, school, and recreational activities as well. All right, moving on to soft tissue tumors. Here are a few benign examples of soft tissue tumors. One of the most common is called a lipoma. It is the most common soft tissue tumor. It is relatively superficial. It's located in the subcutaneous tissue just underneath the skin, and they are typically asymptomatic, kind of like a fatty tumor kind of thing, where you'll see a lump, a bump, soft tissue on the skin. Ganglia arise from the joint capsules or tendon sheaths. We tend to see these a lot on the dorsum of the hand. Pain and tenderness may or may not be present. Sometimes they're completely painless. Sometimes they are sort of tender to the touch. Popliteal cysts are also known as Baker's cysts. These typically occur at the back of the knee, in the popliteal space. They are a subtype of a ganglion. They can be very painful, especially if they rupture, and the most common sign is going to be swelling on the posterior aspect of the knee. So I do have some pictures to show of these. So this would be a ganglion cyst on the hand. Down here we have a lipoma on the skin, and here we have a Baker's cyst or a popliteal cyst on the back of the knee. Other types of benign soft tissue tumors include a nerve sheath tumor or a neurofibroma. It's a tumor of the nerve sheath that arises in a peripheral nerve. They are generally superficial, relatively painless, and benign. They can be just one or they can occur in multiples. Schwannomas are a rare tumor of the sheath that surrounds a peripheral nerve. Remember, nerves have that Schwann cell covering, that myelinated covering to help the nerve signal travel a bit faster. So this is a tumor that arises in those Schwann cells. It can be either benign or malignant. Malignant are considered neurosarcomas or a neurogenic sarcoma. And both of these arise from the coverings of peripheral and cranial nerves. Whoops. Here are some pictures. These are cutaneous neurofibromas. So you can see them here on a person's back and on the back of the head. All right, malignant soft tissue tumors can include a malignant schwannoma. So we just talked about how those can be either benign or malignant. These are also known as neurosarcomas. They are a rare nerve sheath tumor that arise from the Schwann cells, generally slow growing, usually pretty painless, but they can spread. A rhabdomyosarcoma is a malignancy of striated muscle. It can occur at any muscle of the body. It is of unknown cause, and again, it's usually a painless mass in the soft tissues. It is seen more commonly in children, but it can arise in adults as well. Liposarcomas are slow-growing tumors that can achieve a pretty large size, typically located on the thigh, and at least 50% are located on the thigh, and we can see associated pain and weight loss with these. Epithelioid sarcoma. They are small, firm, slow-growing masses, typically found on the extensor surfaces of an extremity, but can also occur in the shoulder. And they usually develop deep enough that they are undetectable on physical examination. So you can't palpate these. We usually don't see these easily. All right, let's talk about some metastatic tumors. Again, metastatic tumors often metastasize to bone. We talked about this in the oncology chapter. So skeletal involvement represents the third most common site of metastatic spread, meaning that the cancer started somewhere else and then spread to the bone. The first two are the lung and the liver, and then bone is, again, the third most common site where cancer will spread to. Primary cancers are responsible for 75% of all bone metastasis, and again, cancers generally spread from the prostate, breast, lung, kidney, and thyroid to the bone. The spine is going to be the most commonly affected bone when cancer spreads, with more than 50% of metastasized cancers affecting the spine. It's usually the thoracic or the lumbar spine. And again, this is talking about hematogenous spread, meaning that it has come from another organ, typically through the bloodstream, to then metastasize in the bone. When cancer metastasizes to bone, the patients will report pain, which can be sharp, severe, mechanical, which means it occurs with movement. It's often worse at night. It can be constant or intermittent, sometimes with weight bearing, sometimes even at rest. If there is spinal cord compression, this is one of the most serious complications of bone metastasis, then we will also see some nerve involvement. It can cause pain, numbness, and possibly even paralysis. We might see loss of mobility that requires bed rest. We'll see generalized weakness that can increase the risk of developing a blood clot, pneumonia, hypercalcemia, which is increased calcium in the blood, and atelectasis, which is collapsed lungs. We also do see pathologic bone fractures a little bit more in this population. Diagnosis is going to be like with any other soft tissue tumor, radiographs or x-rays, bone scans, CTs, MRIs, lab values may help with this as well. Medical management, once cancer has spread to bone or metastasized to bone, it does become more difficult to treat. Again, as with any cancer, if it spreads, if it metastasizes elsewhere, it now becomes more of a challenge to treat. So we talk about curative therapy versus palliative treatment. Curative therapy are things like chemo, radiation, things where we're trying to attack and kill the cancer cells. Palliative treatment could include those in order to try to make the patient more comfortable. But with palliative treatment, we're really just trying to make the patient comfortable, knowing that a cure might not be possible. Generally, in both cases, we are going to aim for pain relief, try to control the disease and keep it as local as possible, try to make sure that the bones are staying as stable as possible or protecting the bones if we are afraid of fragility there. And then surgery may need to be performed for pathologic fractures to repair those or to decompress neural tissue. If the bone tumor is putting pressure on a nerve, which is causing nerve symptoms, pain, paralysis, then they might do surgery in order to try to restore normal function there. As with any type of cancer, early detection is going to be essential, and the presence of musculoskeletal pain may be the initial symptom. A lot of people with musculoskeletal pain get referred to PT for treatment. So we need to be kind of on the ball and making sure that we're taking thorough histories, that we're talking to our patients, and really trying to find the root cause of their pain. Exercise, it's recommended for individuals with bone metastasis, both before and after surgery, to increase their muscle strength and endurance, and still making sure that we're protecting the bone. Stretching may be necessary to prevent contractures from forming and to increase a patient's overall range of motion. High impact and high torsional, so like running, cutting, twisting, those types of activities should generally be avoided, again, because we may be worried about fragility of the bones. And isometric exercises may be encouraged following chemotherapy. Isometric exercises, by definition, are contracting the muscle without joint movement. So they're kind of a gentle exercise, which may help to delay atrophy of the muscles. Fall prevention is going to be huge with this population because if they fall, they are probably at a higher risk for fracturing a bone because of cancer. So balance training may very well be a part of their physical therapy. Proper breathing techniques, especially patients with lung cancer or cancer that has metastasized to the spine. Gait training, bed mobility, transfer training is all going to be essential to make sure that we are maximizing function with this patient population. All right, so that is it for metastatic or musculoskeletal neoplasms. If you have any questions, please feel free to reach out. Thanks.